Welcome to tonight's VetCat webinar. Our speaker tonight is Dr. David Sarment. Dr. Sarment is a researcher at U of M. Dr. Sarment served as a clinical investigator in the original NIDCR grant, which helped found Xoran Technologies. Dr. Sarment is the author of 2 textbooks, including cone beam computed tomography for maxillofacial applications. He is the author or co-author of 6 book chapters and over 30 peer-reviewed scientific articles, and has lectured nationally and internationally on topics of periodontics, surgery, cone beam CT technology, and surgical guidance. Through his work as the product manager for Xoran's veterinary market, Dr. Sarment has developed key relationships with veterinary clinicians and leaders in the US and in Europe. At this time, I will turn it over to you, Dr. Sarment.
Thank you so much for the introduction.
You're welcome.
Thank you all for joining tonight. It's a real pleasure having you. Tonight we're going to really go over some of the reasons to go from 2D to 3D, and some of you on the call tonight have already sort of made the transition into 3-dimensional radiography with cone beam CT, and some of you have not. I really hope that if you have any questions, just jump in, type them in so I can answer them. It's been a fantastic journey for me over the last couple of years, really, to see veterinarians start to adopt 3D X-ray CT with the VetCat. But in reality, it's really been a journey for about 20 years, actually, to get to where we are now. So I'd like to today to sort of share with you the vision. I've had a chance to watch some of you do procedures, discover veterinary, I'd like to share with you what I think is going to happen over the next few years and is already happening in some of your practices. And I want to suggest to you that now is the time, and I'll tell you why in just a moment. We'll then jump right in and talk a little bit more about cone beam CT and CT in general, and how to make the change for those of you who haven't done it yet. And those who have done it, I'll share sort of my general experience. So here's an unrelated topic that really changed my view of going from 2D to 3D. This is a picture of a heart looking at a mitral valve. And the reason why I'm showing this to you is because I was sitting with one of my friends, a school friend from med school who had gone into cardiology. And he was showing me this 3D rendering of a mitral valve, which you can see here on the screen on the upper right. I had always seen ultrasound of the heart, and I'm not a cardiologist by far. I really don't know how to read this, and yet I was trying to make sense of this over time just to educate myself, and I could really never understand much of the anatomy of the heart. And this friend cardiologist shows me that now, instead of using this basic ultrasound in 2D, he has renderings in 3D that are routine now for him. And so the sort of images he now sees are on the upper right. And what's amazing about this image of the mitral valve is that it's actually very clear. You don't need to be a radiologist to recognize the anterior leaflet, posterior leaflet of the mitral valve and get a sense of the anatomy and the orientation. But what I found even more astonishing when I was talking to him about this a few years ago is I told him, look, this is a beautiful picture. I get it now. It's useful to me, but how much more information do you get on a routine basis? Because you've done this for so many years. This to you is completely natural. And he answered to me, said, look, now that I have it in 3D, I finally understand the anatomy and the pathology a lot better than I have for the last 15 years. And that really was a turning point for me, because I realized that even him with this huge amount of experience still was struggling with some details of the pathology he was looking at. And he was describing to me that the orientation, the details of the pathology showed better in 3D. And here on the bottom screen is sort of an evolution of what we're witnessing now. And it's exciting for you who are on the call today and are looking forward of the next few years. You're really at an amazing moment of time where we now have these very, very fine tools due to advancements in computers, in software, in reconstruction mechanisms to get into a whole new level of diagnosis and treatment planning. So I like to show this image of Plateau. Most of you probably know this, the story of Plateau, the allegory of the cave. So this is Plato's telling that the world is viewed by all of us almost like those prisoners in the cave, in Plato's cave. And we are in fact looking at a projection of an image of the reality. And we're all sort of going through this. And with enlightenment, it's an image, of course, from Plato. With enlightenment, we step out of the cave and we see the world in a whole different way. And it just dawned on me not very long ago that that's sort of what has been happening with 2D radiography moving into 3D. We've been looking at projections of what we think is pathology and what we think is the anatomy. And once we can finally turn around and look at the light, in 3D, everything looks so different. I actually think now that Plato was thinking of veterinarians because a lot of these images have animals on them. So I can only assume he was already thinking ahead for you. So as a result, what do we do now? We have these 2D projections from 2D imaging, and with three-dimensional CT scan, all of that turns into 3D. It's relatively quick, and the resolution, the quality of the images is quite significant. The resolution in the bone window in particular is as little as 0.1 millimeter cuts all throughout the anatomy in various directions. The three-dimensional reconstruction is such that you can rotate the anatomy in real time. And the devices themselves have really simplified. The VetCat in particular, as you can see it here on that quick video, is relatively simple to use. You can move it around the office. It's a big cart. So some of you who just started using the VetCat are very well aware that the use of it, the practical use of it is relatively straightforward. It's a lot less complex than a full body CT or any sort of older imaging modality that needs a lot of training and a lot of practice to be able to manipulate the device itself. It's still a very complex machine, but it's compact now, it's fast, and the information is almost in real time. So why now is the time? Well, in the world of veterinary, we have really made the shift where we can afford to get 3D imaging under a single anesthesia and really get the information in real time and provide comprehensive care by being able to see details of the anatomy and the pathology at a speed that wasn't available to us not very long ago. So here's an example of a tumor to demonstrate that we can really elevate the level of care. There is something going on. We can see it on this two-dimensional radiography. And as soon as we have a CT of this in a high resolution bone window, the shape, the exact location, the extent of the lesion becomes very obvious. We can tell here that it's still bone limited. It's not invading the nose and so on. This is a different case here in the middle of the screen, showing another tumor that is a lot more aggressive and very quickly and relatively easily we can define the borders of the tumor. And what's interesting about CT in particular compared to, say, even ultrasound is that the images are relatively easy to read. I get that question a lot, how long is it going to take me to learn to read CT? And reality is that you are clinicians, you're the experts. You know your patients, you know what to look for. And this is simply cuts of the anatomy in all directions. It doesn't take very long for you to truly recognize the pathology because it's typically clear and a lot more straightforward than actually a 2D X-ray. So let's look a little bit very quickly at a couple instances of what the science has shown us. And this is a study we did very early on to compare two-dimensional radiography to CT scan. This is done on human dry bone, so very simple study. And at that time, this is in the early 2000s, we were trying to verify if the accuracy of the images on cone beam CT was as good as it was advertised, in whether we had any sort of worry about the distortion or the image quality. So we simply took two-dimensional X-rays. They were calibrated as best we could. We did direct measurements on the dry bone. And then we compared as precisely as we could all of those measurements. This very basic lab study showed that CT is accurate in all directions. This is no longer a surprise, but at the time we had to establish that. And it's as good as or slightly better than direct measurements, even on a skull. And of course, it also has the benefit of being able to measure bone level, intra-bony defects, furcation involvements, and in the case of regenerative therapy, to be able to do follow-ups in a way that's superior than traditional X-rays or even clinical measurements. And the reason for it is that you have the ability to measure in all aspects of the anatomy, not only mesially or distally, but also buccally, lingually. And you can really have a 3D understanding of the defect or the repair. This basic set of studies in this book chapter here is a review of further studies. This was repeated over time, not only in the lab, but also on patients. Now, in veterinary, there's been a number of good work, and it's still in the works now. There's publications coming out now. And I just picked a couple of them. You probably are, most of you are familiar with them. This is early on, this is 2015, so a few years back, not very long. This is also to show you how quickly things are changing. Just a few years later, we find ourselves really a step forward. The Sokup's group, and I know you recognize many of the names on the list here, did a study where they compared conventional CT to cone beam CT. So this is yet another question. And they did that in the lab as well. They took dry samples and compared conventional slice CT using a 64 multi-detector CT to a cone beam CT they had available at the time. And what they showed is that the cone beam CT actually is superior for the purpose. Why is that? We'll look back at the technology in just a moment, but the ultimate reason for it is that cone beam CT has the particularity of giving you high resolution in the bone window, meaning high details of bone anatomy. And you can sort of see this right there in their well-written paper. This figure here really shows you the story in one picture, where you could see the conventional CT versus cone beam CT, and you can tell immediately that the cone beam CT just has that much more resolution in that specific situation. And I'm specific with the wording because conventional CT, of course, does miracles for all sorts of other situations where cone beam CT is not a good solution. One of them is speed. So if there is motion like hearts and lungs, cone beam CT is not a good modality because it rotates way too slowly for imaging a heart, for instance. But for anatomy that's stable, where a few seconds are not critical to the image quality, and where the bone window is the most important, then cone beam CT has the particularity of giving you a good resolution. And we'll look at that a couple more times. There's just a couple other papers. I'm sure many of you are familiar with those. This is Dr. Doring, who's a resident at UC Davis just a few years ago. She's now back in Europe. And this paper and a couple others have just in a very elegant way looked at cone beam CT for the purpose of various clinical needs: missing teeth, abnormal eruption, rotation, periodontal disease, tooth integrity, root resorption, and periapical lesions. And they found, by looking at those various elements that are critical to the clinic, that cone beam CT indeed provides details that are typically more significant and more interesting than traditional dental radiography for this particular patient. So in this particular set of papers from Dr. Doring, she focused on brachycephalic dogs who, as you know better than me, are more complex to visualize with radiographs due to the crowding and mispositioning of teeth. Here's another study from the same group, Dr. Henny, that looked at sort of this similar approach under the same method, but this time looking at cats, and the results are also somewhat similar. Demonstrated cone beam CT has superiority to dental radiography due to the fact that it doesn't have the defects of the projection, and it has high resolution. And that becomes really tricky with cats because the anatomy is so small. So how does cone beam CT works? In the case of the VetCat, you bring the device to the patient. You position the patient. Usually the patient will be under general anesthesia. There are lasers as part of the device to roughly position the patient. That takes usually about 10, 20 seconds after you've done this a few times. So you roll the device over to the procedure table. You prepare the device in such a way that it's positioned properly using those lasers, and the lasers sort of tell you where the image is going to be. And then you go ahead and scan the patient like we saw earlier in the video. And what you get is these three-dimensional cuts. How we go about doing this is we reanalyze the projections, the X-ray projections, and we're able, by formulas, by mathematics, we're able to assign a gray value within the volume of the anatomy that was imaged. And we call these very small units voxels because they are pixels in 3 dimensions, so we call them voxels. And those voxels have a dimension themselves. So this is the smallest sort of little area you can see on the image if you zoom in all the way. In the case of cone beam CT, the voxels are the same in all directions. We call this isotropic. And that is different than most conventional CTs that tend to have a better image in the X, Y direction, so in the cut versus the long axis of the patient. In the long axis of the patient, typically the Z direction, the long axis of the patient, the voxel size, so the distance between one slice and the next slice in conventional CT tends to be higher, bigger than in the X and Y direction, which is not the case with cone beam CT. Why it's important to us? It matters to us because when we look at an image in cone beam CT, it doesn't really matter which direction we look at it. We can cut off the anatomy in all sort of ways using software tools. And ultimately, the image quality is the same in all directions. We also take this information and assign it a gray value. So those are ultimately presented in what we call a multiplanar reconstruction view, which is cuts in different directions. And we'll look at that again in a moment, in gray values. And this is very arbitrary, by the way. The reason why we do it this way is because that's how CT scans started back in the 70s, and traditionally we present it this way. And by convention, we sort of keep up with the anatomy layout on the screen so that it's consistent over time. And that's really the main reason for presenting it in this particular way. But the gray values are not just values of gray on the screen. We call them Hounsfield units. They are calibrated. And these Hounsfield units have, by definition, a value of 0 if it's water. If it's air, it's roughly minus 1,000. And then, of course, bone is going to be denser, so the gray values are going to be higher. Now, our cone beam CTs have a decent resolution in terms of those gray values, but maybe not quite as good as conventional CT. In other words, the calibration of those exact Hounsfield units in conventional CT is a little better typically than cone beam CT. So the cuts is what people get confused with. You know, what am I looking at on the screen once this pops up? Good news is there is immediate 3D reconstruction, so you can look at the 3D while you're looking at the cuts, especially in the beginning. But your true diagnosis and the details are in the cuts. The 3D rendering gives you a nice looking image, but it has limited value for small details of the diagnosis. In our case, we actually present the 3D with sort of color-coded planes, so you can recognize which cut is which. But roughly, these views show the anatomy in all 3 planes. So sort of axial view, the sagittal view, and the coronal view, up and down the anatomy, are presented at the same time. And then we can travel through those cuts. And again, they're cuts by convention, meaning we present them that way. Although cone beam CT is a volume data, meaning that it doesn't matter which way we look at it, the quality of the image is the same. So how to make the change from 2D to 3D? Well, it's actually pretty natural. If for some of you who are on the call who've just started using your device, you probably realize that the transition from 2D to 3D is actually pretty straightforward. It takes a little getting used to, but what is actually the biggest challenge is to understand what is pathology and what is not, because some of the pathology will show up so much. And sometimes the normal anatomy looks like pathology to you initially because it was sort of blurry in the past, and now it's very obvious. So here's just a couple examples. Here's one of them where this is a case from Dr. McTaggart. The two-dimensional radiography shows embedded roots. Where are those roots exactly? What is going on with this anatomy? Where is it buccal palatally? We don't know. But as soon as we take a CT scan, everything becomes very obvious. There's a very large cyst in the maxilla right below the orbit. And then we'll look at that again in a moment. If we look more closely, we can immediately identify those roots, know exactly where they are, and we can approach the surgery in a lot more conservative way. So we're not sort of digging through the bone, creating a larger ostectomy, and then figuring it out on the fly. Instead, we can truly tell exactly where we're going to find that root. and how we're going to go about addressing the pathology surgically. And what I found on the human side, when we started to do conbeam CT in particular, because it became so easy to use for us as well, is that we were so predictable in our surgeries that all that was left in surgery was how quickly can I do the surgery? We already knew exactly what surgical approach we're going to do. We knew exactly what we're going to find. And what is left at that point is how well am I organized to get into surgery, get down, suture, and get out and just go faster. And as we know, faster doesn't mean it is a fast surgery. It just means it's an efficient surgery. And because it's efficient and more precise, patients heal that much faster and that much better. And your approach can be more conservative. So I always like to show normal anatomy because this is where we should start. So here's normal anatomy in the various cuts again. So this is axial view, another axial view here. Here's a buccolingual cut. So this upper right quadrant now is not one of those three planes. This is yet another cut, another sort of approach, which we can create at any time, at any point. We can actually artificially make another cut of the anatomy if we want to and focus on one area. And we can do this in all directions, including buccal palatally through a root if we wanted to. And if you've not seen this before, you'll notice that normal anatomy is going to look different to you because you haven't seen it before. But in reality, if you think through what you already know from histology and from school and from your clinic, all of this becomes very obvious to you. This is bone level. This is the buccal. This is palatal. That's the roots. This is the endodontic canal. This is normal bone level. You can tell that it's about 1 to 1.5 millimeter away from the cementoenamel junction. You can see the thickness of bone on the buccal aspect of the root. You can recognize the thickness of the periodontal ligament. You will actually notice that the periodontal ligament, and this here is normal, will vary in thickness from place to place and from patient to patient. Younger patients will have larger periodontal ligaments, will also have larger endodontic canals. But within the same patient, you'll see a variety of thicknesses of ligaments due to the function. And actually, I've seen this a lot where you see a ligament, wider in one spot, narrow in another spot, and you can almost infer the sort of pressures and the movements that's being put on these teeth just by looking at the thickness of the periodontal ligament. I find that very interesting and very telling in some of the cases. Here is normal anatomy, and you can tell the proximity of this root to the nasal cavity with very thin bone. That's all normal. You can also imagine if there was any sort of pathology, say a periapical lesion, it just wouldn't take much for that bacterial infection to go right into the nose, because that is very, very close to the apex of that tooth. This image is showing you a different sort of patient. If they're small enough, you can picture other areas of the anatomy, and we'll take a look at a couple of those extremities as well. But what I want to point to you is that yet it is a nice looking 3D, and it is going to be very useful for spine and extremities. But when it comes to things that move, and this is the top of the lung, you can already get a feel that we're starting to lose a little bit of that image quality that we had in the previous pictures, because the lungs are moving just enough in this patient. This is not under general anesthesia with intubation. It's just enough movement in the lungs to cause a little bit of blurriness, because those images were acquired through a rotation, which took about 30 seconds. And that is enough time to cause a little bit of blurriness. Here's an interesting situation with endodontic treatment. where you can evaluate your field. So this, you could do the imaging before and after, due to the fact that the device is easy to bring over. It doesn't take much to take a second scan right after treatment and see if you're happy with your field, especially in more complex cases. If there are any sort of voids of your field, that'll be very obvious to you. For trauma cases, 3D is really a huge advantage, especially in the 3D rendering itself, because now you can see exactly where the fracture lines are. And you can, just by looking at these images without even spinning it on this particular slide, you can already tell how you're going to approach this. What can you reduce? What fractured bone you may not be able to reduce? What are you going to expect surgically? What are you going to find? A lot of decisions can be made just by looking at the image. It's easy to do it from your desk, from the station, from the VetCat station. And you can make a lot of decisions right there before you step into the procedure. Here's another fracture case, of course. This is a different patient from Dr. Farkas. A little bit later on, when you can retake a scan at some other time points. And this is a beautiful demonstration of a reduction with the plate in place. You can see the screws and appreciate the healing over time. Here's another interesting case from Dr. McTaggart to discuss just basic extractions. You're approaching this area and you want to do an extraction. Not only you need to do the extraction now, and you can really tell root resorptions and so on, but you're going to start changing the approach of the extraction. That's been published. Dr. Berning has a very elegant paper showing the relationship of roots at the mandible to the mandibular canal. But here's another situation here, where there is a defect on the buccal aspect of the root. You can see it here in 3D, and you can do a quick measurement. This measurement is accurate. There is no distortion because it is a CT. And this immediately tells you how far you are from the orbit. That's before you even enter the procedure. So now if you have to take out this tooth and do some sort of luxation of the root to remove it, you already know that you only have a couple millimeters before you're meeting the floor of the orbit. And you can then change your technique slightly, maybe stay away from this, or know that at least your instrument should not penetrate this defect very much. Because the CT is accurate in all directions, you can actually look at roots and arches in all sort of directions, including sort of a free fall direction, sort of tracing in whichever way you want. So you can actually follow a root and flatten it on the image in such a way that you've not seen before. So you can actually follow an anatomy, the root or the nerve or any sort of other area, and make it flat so that you can see the anatomy all along as if you were sort of looking at the root itself, flattened in front of you. There's lots of details that will start to become obvious to you. Here's just one quick example of a non-reduced luxation of this root. And you can tell what happened, you can tell the history of the situation by just looking at the CT. So here is the cortical bone where the root used to sit. And this is a few weeks after the trauma. You can tell there is already some good healing. And you can sort of tell that this is new bone forming. You can really tell that this is no longer a time to try to reduce this in any way, shape, or form, and probably just leave it the way it is. And if you took that CT again, a few months later, you would see that change because the trabeculation is there and it's showing on the CT, so you have that level of detail. And here is this same case I just showed you a moment ago, but in a different view now, where we can take the 3D and cut it off, crop it, And when we crop it, we can sit on the tongue, sit on the roof of the mouth and look at the defect. And now everything looks really, really large, although it's very small on the patient. It looks large. We can zoom in and see that root sitting into this defect. Everything becomes very obvious to us because we can turn on this anatomy to our advantage and crop it off and really look at some details in a view that's not available in any sort of projected image. And another point here showing us two CTs of the same patient over time. Now these are the clinical views showing necrotic bone and its healing. And the CT will show you also the evolution of the healing over time as well, both in 3D and even more in the MPR view in the cuts. An interesting view of a temporarymandibular joint, which obviously has significant pathology, probably due to past trauma. Yet you can appreciate whether there is a ligament or not. And if you wanted to approach this surgically, you can, because you have all the details. You know you're going to find a ligament space. You know how far you can go if you wanted to surgically remove all of that. You also know how far you should not go because the brain is right behind it. And finally, here's just a quick video showing you the manipulation of this NPR view and how quickly you can travel. Here focusing on ear disease on this cat. You could clearly see the details of the bulla and appreciate the pathology within the bulla. This is bilateral acute pathology. Why we know it's acute? Because you have sort of a water level of this pathology, and you have preserved bulla walls that look intact. They're still very thin. They haven't thickened. So we can do a lot of diagnosis by looking at that image as well. In contrast, here's a more advanced ear case with very thick bone. This is a case from Dr. Croatian in California, showing this very invasive chronic disease, this time so invasive, in fact, that it breaches the base of the skull. Dr. Bannon and a few others have done some contrast cases, and what we mean here is injected contrast. So the patient is injected a few seconds prior to taking the CT. Cone beam CT at this particular time is not quite as good as the conventional CT, but we're working out those problems. We're actually right on the edge of making that happen. And those contrast CT on the cone beam CT is actually quite reasonable. So if there is pathology, you'll see it with contrast. The question is, do you sit beautifully or do you sit enough for the purpose? And it seems that the experience is not huge. We don't have a ton of cases done with contrast CTs, but from what we've seen, the clinicians who have done it show that the image output is actually useful and lights up the tumor when you need to sit. There's lots of other applications. We've just touched on a couple points today. Of course, one of them is exotics, small animals and very thin, and a hollow bone will actually show well on cone beam CT again because of this high resolution in the bone window. And if you have exotics in your building, they will appreciate the flexibility of using the cone beam CT for their patients as well, because they'll be able to typically see anatomy in a way that they don't have access to in general and in a relatively easy approach. So I hope this was a useful overview to demonstrate to you that really cone beam CT has come to the point where it can be a part of your routine day. It has been for several of you. Some of you are coming on board now, and it's exciting to see this happening. If you have any questions, I'm happy to answer them. Dave, if you can tell me if there were some questions that came up, I'll be happy to answer them.
David, this is Jim. I'm getting a couple questions on my text here about, I guess you're in final testing of a slight variation of software that people are looking at.
Yes, we always are. There's always the next version of the software, yes. We're constantly trying to do a little better. Actually, a lot of the new features that you see come from the users. You know, the positioning of the patient on the screen. Can I flip the image to the left? Can I flip all of these images? We're doing that. The sort of measurements, the embedding of the 3D in a slightly different way. We're doing that. There's also always some new sort of improvements and tools to help the presentation of the anatomy on the screen based on your use, but also the workflow within the office. So we're always looking for, you know, how easily can you demonstrate these images to the owners, or refer the file to a referring doctor if you want to share that with your general practitioner referring to you. And if you are a general practitioner, if you want to share this with a specialist or radiologist, all of that sort of flow of information is constantly getting a little better and a little faster every day. One thing that I'm intrigued in, I see a question here about trying to relay. This is an interesting question. I also got it in the text message. You know, how do I actually, let me go back to one of those cases to help answer the question, if I may, for a second. So imagine I have this 3D here and I'm looking at it. How do I actually take that into the surgery? What are my reference points? Where do I measure from? And once I go in the surgery, yes, I do know the anatomy better, but how do I take that information into the surgery? Where do I measure from and so on? And that's really an interesting question. We actually are trying to chase that a little bit more now as we speak. At the moment, you have to look for stable anatomy, say the distal of this tooth. You can take a measurement on the screen from one spot to the next and say, okay, I am 12 millimeters from the distal of this tooth to where I want to do my cut. So you can go in the surgery and measure that. In the near future, there will be sort of GPS looking tools where you can go into the procedure and point to a spot that matches something that you see on the screen. That is not too far-fetched. It sounds like a little much, but it's actually not too far out of the realm of possibilities, mostly because those tools have been in existence for other procedures, other situations. So we know it's possible to eventually sort of bridge that gap. So that's a good question.
While we're waiting for a few more questions, everyone, we just put a poll onto your screen. If you would take just a second to answer that, we'd like to those answers tallied, and then we'll share the results. At this time, are there any other? I do have one question, David. It is, what does in-office training look like once purchased?
Yeah. So we do this in stages, actually. It's more than in-office training. It's a really good, very important question because it's a process. The in-office training is when the device arrives and we go through a sort of a formal training, and we try to really give you as much information as we can. And it's formal in the sense that we show you how to position, how to take the scan, and so on. In fact, Jim, who just heard his voice, is actually in the middle of training an office, and I think some of those are on the call as well. And that takes a few days because we want to show you formally how to use the device, and then we want to watch you do the first few cases. But the reality is so we might spend 2 or 3 days in the office to just watch you and see how you not only take the image, which is actually not the hard part, but eventually come around and use the data throughout your office and your workflow. But then after that, once we leave, you're not done. You're not completely trained yet. And so we like to go back and remotely, now with technology it's so easy, we can remotely talk to you, we can watch cases, we go on. And everybody's a little different. But in my experience, it takes a few weeks up to about 3 months to be completely comfortable. And I like to call this 3 months because that's really sort of a good goal, at which point you have had your initial training, we've watched and we sort of went back and forth, and you're fluent, meaning that it's just that device is just part of your office. It fits and it works in your workflow and you've adjusted your workflow with it. So it's not just those couple days initially. There's another question here. Can you explain why this is only being used for ENT specialty practices? The unit is able to produce. So on the medical side, it is true that Xoran in particular focuses on the ENT. And actually the device used by ENTs is not the device that you just saw now. It's not the same as the VetCat. It's a slightly different machine. The main reason why we've been focusing on ENTs is because ENTs, compared to, say, dentists, need a very high quality image. Why? Mostly because of sinuses and ears. And in fact, the anatomy of the ear, like you saw in some of these images, you can see it on this one, is one of the trickiest anatomy to image properly in the body. It's a very dense bone with very, very small middle ear bony chain. And that anatomy is very difficult to picture properly with cone beam CT, in fact. And we've made it our specialty to develop techniques that are optimized for very, very high resolution for that purpose. And that's the reason why most of our medical users are ENTs here in the US, in practices, in private practices. Typically, although we have a lot of maxillofacial and now some neurosurgeons and neurologists using a device that looks more like the VetCat in the operating room for trauma, reconstructions, orthodontic surgery.
Dr. Sarment, another question. How many units do you have in veterinary or veterinary dental clinics?
So we are relatively new compared to the medical side, where we have many, many hundreds of devices all around the US and in fact all over the world. In veterinary, we have about 35 units now in the United States.
Dr. McTaggart requested the GPS function, just to let you know.
Ah, okay. It's coming. It's coming. This is the next sort of level, and Sue, I will make sure to let you know that you have the first GPS. That sounds good.
David, one more question here. Has this been used in the equine industry or just small animal?
It's been mostly small animals. There are a few sites that have exotics. We only have one site in a zoo, so there's larger patients used there. It hasn't not been used for equine, mostly because the form factor of the device is really not ideal for this. The shape of the machine is such that it would be very difficult even to image the head of a horse. It just would be, the anatomy is too large, and just the machine itself is not set up for that purpose. So the vast majority is small, practice patients. Thank you. That was a great set of questions.
Don't see any more questions here, David.
Okay, thank you very much. It's been a pleasure having you. Please reach out if you have more questions. We look forward to hearing from you. Thank you all for joining tonight.